Well, I'm Juan Bowen. I'm at the Mayo Clinic and work in our Marfan and Aortic Disorders Clinic. I also work with the Marfan Foundation on their professional advisory board, and Dr. Heidi Connolly from Mayo is the chair of that board. So I really appreciate the invitation. Now, you don't have to worry about me giving you lots of details about cardiology and cardiovascular surgery, because I'm not a cardiologist, I'm not a surgeon, I'm an internist. You don't have to worry about me giving you too many genetic details because I'm not a geneticist. But I've been working in this field for some time and saw my very first Marfan Syndrome patient in 1980 when I was an intern at Ohio State University. And my professor told me, this is a very unusual condition. She's in here with an infected heart valve, and you and I are going to keep her alive. I thought, me? I was just out of medical school. But we did. But that was the first time I saw the Marfan syndrome. That was 11 years before the gene was identified. So I'm just going to say a few historical things. I'm going to watch my time. I have 30 minutes. I'm starting at 5 till, okay. I'm going to say just a couple of comments about the biology of the aorta and then the various conditions that we treat in our clinic. The history of this is really important. The term heritable disorders of connective tissue was coined by Dr. Victor McCusick, who was a cardiologist and chair of internal medicine at Johns Hopkins, but is also known as the father of medical genetics. Is Gretchen McCarrick here? She's here? Maybe she. Okay, so I hope that she would say that that's accurate. He named the condition after Dr. Marfan, who had described a patient in the medical literature who had physical characteristics that appeared to be those of Marfan syndrome. And then this field really began to change when surgical techniques were developed so that the aorta could be operated on, and this was in the 1950s. You heard about Dr. DeBakey before. This is a photograph of Dr. DeBakey with his wife's sewing machine, because at the time there were no vascular grafts being made, there were no manufacturers. They tried nylon, but nylon didn't work, and he thought, well, there's Dacron, so he bought a yard of Dacron, and he borrowed his wife's sewing machine, and he made the first vascular graft that worked. Then a London surgeon, Hugh Bentall, really developed the operation that is today a life-saving operation that some of you maybe have had. And this is the composite graft where the pre-formed valve and Dacron conduit come together from the manufacturer and are implanted into the person. And this was a huge development. And then in 1991, these are just 3 of the people, but there were others, who identified the causative gene, the mutation, that causes Marfan syndrome. So that was a huge step forward. And then since then, other genes have been identified. There's a giant in this field, this Diana Milowicz at the University of Texas in Houston. And VSMC stands for vascular smooth muscle cell. So there are proteins in the smooth muscle cell that become mutated and cause aneurysms. And then we're now in the era of clinical trials. So in a generation, or a little more than a generation, we've gone from recognizing the pattern but not being able to do anything about it to actually having medications that are good enough that clinical trials can be organized. And Dr. Lacroix was the lead person in an important clinical trial. And Dr. Reed Pieritz is one of the giants in this field. He's retiring this June from clinical practice. He was at Johns Hopkins for many years now. He has been at Penn. And he has written some nice paper kind of talking about how you have to invest in basic research if you expect to get anywhere. This is how so many other things in medicine have been done, and this is no exception. But once you do invest, then you do get results. So back before this investment in research in this condition and related conditions, this was the situation. Didn't really understand the biology, didn't have good treatments, did not have animal models. So nothing to really use in clinical trials. But today, we know a lot about the biology, not full everything. We have excellent surgery, as you already heard. We do have animal models. We have, I wouldn't say fully developed medical treatment that's going to keep people out of the operating room, but emerging medical treatments that do work. We now have human trials, and we now understand it's not just Marfan syndrome, but it's Marfan syndrome and related disorders. I'm only showing this slide just to demonstrate to you that the biology of the aorta kind of depends on its embryology. So if you look at each segment of the aorta, it really has a different embryological origin. And this is an important point. This is why some of the conditions vary from each other. Now, it's also really important to understand that the aorta has elastic fibers that are kind of concentric rings, and they're sort of like rubber. They store energy and then they return energy. And when they return energy, the aorta has its normal function. But if the elastic fiber system, and there you see that pulse wave velocity, everything is normal. But when the fibers become fragmented, the pulse wave velocity speeds up, and then there's a rebound wave, and this is damaging to tissue. So this is a sick aorta, and this is elastic fiber fragmentation. Now, microscopically, the cells that, I'm not sure that I have a pointer, but maybe I do. Yeah, well. So maybe I'm using it the wrong way. So these are the aortic smooth muscle cells, and this is the fiber network. And there are a lot of little microscopic connections that are molecular. And there are a lot of, in other words, many things that can go wrong, many mutations. This is what it looks like under the microscope, and the dark areas are fragmented fibers when they're supposed to look like this. So this is what goes wrong in a dilated aorta. So you have these broken fibers, and how do they get broken? Well, they get broken sometimes because of very elevated blood pressure. So a normal person with no mutations but extremely high blood pressure over decades can have aortic aneurysms. This is my attempt at a little cartoon to emphasize that destructive enzymes can digest the tissue, particularly with inflammation. There are forms of aortic disease that are very inflammatory, but even the non-inflammatory conditions have overactivity of destructive digestive enzymes. And then finally, there are signaling pathways, and when a healthy aorta, then the traffic is nice and organized and everything's fine. But signaling pathways, which are necessary for development, can become disordered and can cause damage to the aorta. And the pathway that you hear about over and over is the TGF-beta pathway. And then finally, you can damage the aorta through toxic ingestion of different things. And I'm going to mention the quinolone antibiotics. So there are toxic things that one can do to damage one's own aorta. Now, there are so many of these, and I told you I wasn't going to give you a lot of details, and I won't. I'll just emphasize that in the families of genes, some of these are, this ECM stands for extracellular matrix. So ECM is extracellular matrix. This is that pathway that I told you about. And these are mutations. And these are contractile proteins that Dr. Milowicz has discovered. So it does make sense. There are families and categories and specific mutations under those families and categories. But we're in the room with a patient, we keep this in mind. Our patient might have a degenerative type of aneurysm from hypertension. This would typically be the elderly person. They might have aortitis, which a few people have. We really look for the syndromes. And another really problematic area is people who do not look. A syndrome is a constellation of recognizable physical features. So in the Marfan syndrome, it would involve some skeletal features, craniofacial structure, et cetera. But there are people out there who have a family history, and they have an inherited problem, but they have the word that gets used is phenotype. They have a normal phenotype. In other words, their physical appearance is not syndromic. There's no way that you would suspect an aneurysm just from looking at them. And then the bicuspid aortic valve people are the 1% of the population who, instead of having a 3-cusp aortic valve, have a 2-cusp valve, and they have a high risk of developing an aneurysm. So the process we go through is we review their history, their family's history. We look for syndromic features. We use imaging, as you've already seen, genetics, as you've already heard, and that gives us, we hope, a specific diagnosis. Doesn't always work, but often it does. Once you have a specific molecular diagnosis, then you can make a plan, and then, as you've already heard, this is going to lead to a lifelong care. Now, on the examination, it would be nice if we could really tell what's wrong just by looking at the person, but a lot of times the Marfanoid is the word you'll hear, type of appearance of the very tall, slender person with the long limbs is very nonspecific. So that person may have no harmful mutation. They might have a fibrillin 1 mutation and have the Marfan syndrome, but they might have other mutations. And the Marfan syndrome particularly, I think, is one that is, because it's not super rare, it does get into the public consciousness to some extent. And these are people that some of them have had the Marfan syndrome with fibrillin 1 mutations, and some of them have been maybe thought to possibly have the Marfan syndrome. You recognize Abraham Lincoln. There's a famous actor there. There's the man who played, who's the? Chewbacca. Thank you, Chewbacca, et cetera. And so some of these people had it and some didn't, but they're all kind of Marfanoid in their body type. Of course, we use imaging. We have to be a little careful. This is an example of a patient who, on the outside echocardiograms, appeared to have an aorta of a certain dimension, but then when on an echocardiogram, on a CT, the dimension wasn't 46 millimeters, it was 55, and it was because the echo plane was catching this part of the aorta. So all of us who work in this field are aware of this, and we use the combination of cross-sectional imaging as well as echo imaging when we first meet a patient. And then the genetics, you heard a lot from Gretchen McCarrick. I'll just say that when I, as a non-geneticist, I have to work with a knowledgeable geneticist because it's its own specialty. And then sometimes there's no mutation found, sometimes there's a definite answer, and sometimes it's one of these, the VUSs, which are variables of uncertain significance, and you may not know sometimes. You have to talk to your geneticist for the interpretation. Now, I know that I'm not going to go through every single thing about these syndromes because she mentioned them, but I'll just go through a couple of points. So this would be the typical facial appearance, the typical skeletal changes, the eye dislocation where the lens is out of place, and that's because there are little zonules that hold the lens in place, and those zonules are largely made up of fibrillin 1, and when it's a weak protein, then they rupture. The stretch marks, it's common to have stretch marks, but not this many. And this is elastolysis, and this is the breakdown of elastic fibers in the skin. And these are the skeletal problems that one can see. And a particular problem is this dural ectasia, and I'll show you a case of this in a minute. I will point out that there is one finding that is specific. I said that the phenotype was non-specific, but if the patient has a dislocated lens, then this is supposed to be a little video which played a few minutes ago, but it's not playing now, but that's okay. When you have this problem with this dislocated lens, that's because you have a fibrillin disorder. And when the eyes move back and forth, they really kind of quake and shake like a bowl full of jelly. So these are patterns in imaging. This is the most common pattern in the Marfan syndrome. But we image the entire aorta, as you've already seen in your other cases today, because we look for these patterns. I won't go through every one of the criteria, but on the Marfan website, to really meet the criteria for Marfan syndrome, there are certain things that you check off as you go through the family history, the size of the aorta, et cetera. There are certain features on physical examination that give you so many points. That would be on the Marfan website. Now, this is a woman in our clinic, a young woman who came with these problems. She had a childhood diagnosis of Marfan syndrome, and she was really having pretty bad back pain. She did need the aorta to be repaired, and this was her CAT scan image. So you can see that she's got a really profound pectus deformity with the breastbone is tilted and the heart is pushed over. This would be the enlarged aorta. That was repaired. So that was a successful thing. Now this is the dural ectasia that I told you about, normal on the left and the Marfan appearance on the right. This is her dural system with causes frequently back pain. Is usually not going to be a hugely difficult problem, but it's there. And then she came back several years later, and you can see that the repair of the pectus, she had two repairs. She had a surgical aortic repair, and then she had a pectus repair. So the pectus repair gave her a pretty decent result, as you can see in the right panel. But she was having really severe postural headaches. When she would get out of bed, she would very, very bad headache, and she'd have to get back into bed. So she had a lot of investigation, and she was found to have an abnormal connection from the dural sac into the venous system. And one of our spine surgeons was able to ligate this and control that flow of cerebrospinal fluid that was abnormal. And the technology to do this, even a few years ago, was not there. But today, with improved scanning of different kinds, they were able to figure this out. But she also needs chronic management of her headaches. Now, here's a case that we learned a lot about. This is a young woman who had the diagnosis of Marfan syndrome in childhood. And she did have ectopia lentis, so she really very likely had a fibrillin 1 mutation, although she was never tested. She had had a diarrheal illness for a week before and then recovered from that, came into the hospital with the chest pain. Well, you know, the team in the hospital, of course, worried that she had an aortic dissection, so they got the appropriate imaging. She did not have an aortic dissection, so they thought, well, maybe she's had a pulmonary embolus with a blood clot in her lungs. She didn't have that. So SCAD is the spontaneous coronary artery dissection problem where young women can have a coronary. They don't have to have one of these connective tissue disorders, but so they imaged her coronary arteries and she didn't have SCAD. So what did she have? Well, this is her physical appearance, by the way. And when you see her, you know, one of the characteristics of the Loeys-Dietz syndrome is a double uvula, and she had that. So then it's like, oh, well, she's never had the genetic testing. She's got this double uvula. She must have Loeys-Dietz syndrome. But then it didn't make sense that why are her lenses dislocated, because that's a strong indicator that you have a fibrillin disorder. So it was a little bit uncertain what she had. But as far as the source of the chest pain, and this again, you know, I don't know why these things happen. There, it's playing. So what the cardiac MRI specialists have told me is that the uptake on this cardiac MRI, this is her left ventricle. This is the muscle in the left ventricle, and I'll see if I can get this to play again. But if you look at that wall, it is not uniformly, see that little white stuff on the lower part? I'll do that again. So that's inflammation within the heart muscle, and that's myocarditis. And her gastrointestinal illness was with a bacteria called Campylobacter, and she has Campylobacter myocarditis as the cause of her chest pain. So we learned a lot from this case because you still have to go through the differential diagnosis of why people are having a symptom and what's causing the problem. And in her case, this was apparently unrelated to her Marfan syndrome. We did get genetic testing. She did have a fibrillin 1 mutation. And 1% of the population has a bifid uvula. So that is, when you see that, it doesn't prove they have the Loeys-Dietz syndrome because 1% of all of us have it. This is the Loeys-Dietz syndrome, and Gretchen McCarrick talked to you about it, so I'm not going to say much about it other than it's there, and we obviously look for it. We look for the typical physical appearance with the widely spaced eyes. This is Dr. Loeys and Dr. Dietz. This is a patient who does have Loeys-Dietz with her uvula. And they tend to have a tortuosity on the vascular images. So this is a typical type of image. And they can have aneurysms in unusual locations. This is a hepatic artery aneurysm in the artery that goes to the liver. So this would be a typical case of Loeys-Dietz syndrome. And the pattern then would be multiple aneurysms in unusual locations and arterial tortuosity. So this is why we look for patterns. This is a disease that's uncommon, but becoming more recognized. And this is not in the same family of TGF-beta, but it's actually a collagen mutation. We have different collagens in skin and bone and vascular tissue, but the vascular collagen, when it has a mutation, produces this problem where characteristically, these affected people will have a very thin and translucent skin. They will get atrophic scars. Every kid, skins this area of the body, but we don't usually heal this way, but they do with abnormal healing. And this would be a severely affected person, and this is a patient I cared for who had, unfortunately, a renal artery dissection at a young age. Then this is blood that's going into the liver tissue because this hepatic artery aneurysm ruptured. And then she had a very unusual problem, which is really, if you ever see this in practice, this patient almost always has this particular condition. But these images, these are the carotid arteries in the center, and the structure that's also kind of white around that is the cavernous sinus, which is a venous blood flow area. And there is not supposed to be communication between these two. And the fact that there is white dye in both of them means that it's squirting from the carotid artery into the cavernous sinus, unusually in her case on both sides. Equally unusually, it resolved itself, did not require an intervention, and eventually died at age 50, several years after this, and she died of a dissection of a celiac artery, which wasn't even aneurysmal. So this is the problem with severely affected people. This is a lady who was 67 when I met her last year. She lives in Wisconsin. She had had an emergency dissection and with a very nice repair in Wisconsin. And then 5 years later, the phone rang, and it was her daughter. And her daughter said, "Mother, I just watched Grey's Anatomy, and there was a case of a person who had an aortic dissection and who had the vascular Ehlers-Danlos syndrome. Were you tested for it?" So she went to the doctor. "No, you weren't tested for it." They got the test. She had vascular Ehlers-Danlos syndrome, thanks to Grey's Anatomy. But in this particular condition, sometimes the aneurysms are not very impressive, and there can still be bad consequences. And in a Mayo series, this is a composite of all the sites that were affected with aneurysms. And then this is not a syndrome, but it is the 1% of the population. I think this was probably mentioned earlier. I won't say too much about this, but there's not a single gene that causes this. Some of the defects in the aortic valve development are from one of these pathways called Notch, but most of the cases do not have an identifiable mutation. There are several patterns that are recognized on imaging. The valve leaflets are fused in different ways, and then they prematurely calcify. This is a degenerated valve that's calcific and not functioning well. There are several patterns here. This is the pattern of the ascending aorta, and the root would be here at the very beginning. That's normal in this patient. This is probably the most common pattern. This pattern is a root pattern. This is kind of a tubular pattern where they're both affected. But all these patients had bicuspid aortic valve disease, but this is the most common pattern. And it's interesting, they now have the capacity with MRI flow images to show you this is laminar normal flow in a completely normal aorta, in aortic valve. It's just nice straight flow. But this is a patient with a bicuspid valve. So they have a weaker aorta anyway, even if the valve is functioning normally. But here you can see that the flow is striking the aorta here in a higher velocity way, and that's pushing that aortic wall out a little bit. So it's a combination of intrinsic weakness plus the flow characteristics will make it worse. Now, this is a really important category. These are people who have a familial pattern, usually inherited from a parent, one parent or the other. This is an example. This is a patient of mine from Michigan. His brother died at age 33 of aortic dissection, and the grandfather also died of aortic dissection. The family have a totally normal appearance. And in this particular situation, because they don't have syndromic features, they do not get recognized in childhood or as young people. So what happens is what happened in this family. There's an abrupt situation where fatal often, and then people get checked. There's a lot, and numerically, there are more of these people than there are in all the syndromes. So this is a huge problem in medicine. There have been some studies trying to identify genetic patterns. In one study, there was one of the genes that you heard about earlier called ACTA2 that was the more common one, but in another series it wasn't. So there really is not a dominant, easy solution here with genetic testing. Now I'm going to say just a few words about management. I'm already getting maybe 5 minutes. So if you look at the way we would like to all kind of have our lifespan go, it would be to have really normal function, you know, for a long, long time, and then, you know, out here at age, you know, 110. This is what we all want for ourselves. Now, before we had any kind of therapy at all for the Marfan syndrome, you know, the Marfan person maybe didn't have 100% function because of usually non-cardiac problems, but they functioned pretty well. But then there was an abrupt situation with an aortic emergency, often in the early 30s or sooner, and so the lifespan was limited. But today, this is what you have in this particular condition, that people have gained this much life, but it's a life that does have some problems, so there are some functional impairments, but there has been this much gain. And the gain is from surgical treatment. It's not from medical treatment. It is from earlier diagnosis and better imaging and better care, but primarily because of Dr. Bental's operation. What can we do medically for people? Well, we can help them with advice regarding physical activity. Control of blood pressure is critical. And then now, as I said, there were some emerging therapies. Dr. Braverman has provided a wonderful document that's on the Marfan website. And we use this to educate patients and ourselves too about the exercise in the aorta. We now are beginning to have a little science. There was a nice paper published in 2017, and mice with a Marfan mutation were in 3 groups. One was a group that weren't allowed to exercise. Another group were allowed to exercise as much as they wanted. And then another group were forced to exercise. And in those 3 groups, the aorta was the healthiest in the medium exercise mice. And it was unhealthy in the sedentary mice, and it was unhealthy in the over-exercised mice. So we're beginning to have some science in this. Now, what about medications? The reason I have this photograph is because in 1952 in Ontario, there was a problem with turkeys that were dropping dead before they were going to market, and it was because of aortic dissection. So this led to some investigations into why, and eventually they fed turkeys beta-blocking drugs to slow down the lower blood pressure and make the heart contract a little less vigorously, and it worked as turkeys began to survive. So then a trial was done in human beings, and it wouldn't meet today's quality criteria, so it's considered grade B evidence. But it did seem to have some value to beta block patients with Marfan syndrome. But then in more recent years, the angiotensin 1 is one of the pathways in the heart, and this has to do with that TGF-beta signaling pathway. But very impressive studies with Dr. Dietz and others showing that this is a normal mouse. This is a Marfan mouse with an obviously aneurysmal aorta. If you give that mouse propranolol, there's not a lot of obvious benefit. But if you give them losartan that blocks this pathway, then you really nice benefit. So that led to clinical trials, a number of them. The largest one was here in the US, and it was Pediatric Heart Network with 600 patients. And these are always take a little explanation, but just the Z-score would be generally the indexed aortic size in terms of standard deviations. And red and blue are losartan and beta blocker, but the Z-scores went down. In other words, showing that there was benefit. That did slow down the growth of the aorta is the basic message here. Now here's the absolute increase in these aortic diameters. So the aortas continued to grow. They just didn't grow at the expected rate. So it's a little hard to understand, but most people would interpret this as some modest benefit, not the home run that was predicted based on the mice. Just another lesson that mouse and animal models are great, but you're talking about strains of mice. They're not human beings. There's a limited number of strains. There's a limited number of mutations that you can induce in these mice. Human beings have over 2,000 mutations, I think, have been found in the fibrillin 1. So to compare the two is difficult. The animal models are useful, but they don't directly translate into human medicine. So right now, how is this managed? Well, the drug treatments depend on the diagnosis. Then other considerations, as, if the person, for example, already has high blood pressure, then you use certain medications. But I would have to say that right now, this is an evolving area, and medical treatment in 10 or 20 years will look very different than what it does today. I said I would say a word about the fluoroquinolones. These are toxic things to avoid. They have been shown to damage connective tissue through good studies. And so they should not be used unless it's absolutely mandatory. And then when to send patients for repair? Well, in the Turner syndrome, which I didn't discuss, but it's another genetic disorder, there are certain thresholds. Loeys-Dietz is a more dangerous condition than Marfan, and then the bicuspid valve is even safer. So all these considerations have to be adjusted if there are certain risk factors. For example, an adverse family history with dissections in close relatives, or a rapid enlargement of the aorta, or if the person plans a pregnancy. So there's a judgment that's applied to this. And it was already mentioned earlier that this is a lifelong condition, and in Marfan syndrome, there is a risk of future dissections even after elective repair. So this is why people need lifelong monitoring. And then I'm just going to take 1 minute and just remind everybody, which you probably don't need to be reminded, that when Marfan syndrome and related disorders patients now live longer because of effective treatments, they can still get the regular stuff that all of us are at risk for: heart attacks, cancers. So the care of the patients, this would be the kind of tool we use to estimate heart attack risk and decide whether a statin medication would reduce your heart attack risk. This is why we treat blood pressure, because in this slide, looking at the mortality from hypertension, the higher the blood pressure, the more the risk of stroke is what is shown here. So we all want to have a lower blood pressure to lower our stroke risk. This would be a graph that's in a normal person, and that green line is an oxygen level that's quite normal and above 90. But this is a patient with obstructive sleep apnea, where you can see the green often is below 90. In this case, it's a very severe case. So Marfan patients are more at risk for this, so we look for this condition. They do get pneumothorax or collapsed lungs sometimes. And they're more likely to get osteoporosis than non-Marfan. And then obviously, any of us can get colon cancer, women at risk for cervical cancer. So Marfan patients need to keep up and related disorders, their regular care for everything else. Have the colon screening, have the breast screening, have the pap smears. And then finally, just a word about vaccinations. Keep those up too. I think, of course, there are opponents of vaccination out there, but I think what we all need to keep in mind is what the world looked like before we had vaccines. What did it look like before we had a polio vaccine, for example? This is what it looked like. So do we want to go back to that? I don't think so. So keeping up the vaccinations. And then my last slide is, I just happened to see this in the New York Times last year, and it caught my eye that as all of us are aging, we're having some patterns of life that maybe didn't exist several generations ago. And one of those is that we tend to live alone, or just a couple, or you're just by ourselves. And this is a big problem all over the world, but in the United Kingdom, the health service has taken this on and actually appointed a high-level government official in charge of loneliness. So the summary would be that these 30 years of research, as Dr. Puritz said, has given us good results. We need to continue this investment. The Marfan Foundation is one of the major proponents and provides a lot of funding for this, that we have better treatments, but they're still evolving. And then if we listen to our patients, they're telling us that they appreciate the excellent cardiovascular care, but every day they live with mobility problems, chronic pain problems, often a disability, low vision, depression, anxiety. So these are also frontiers that we need to work on to make life better for those with Marfan syndrome and related disorders. So I probably went over my time a little bit, but I want to thank you for the invitation.